Welcome everyone to episode 11 of the podcast on optimal management of cardiac implantable electronic device infection. My name is Julia Vogler. I'm a cardiac electrophysiologist at Asklepios Hospital St. George in Hamburg, Germany. So today's episode will be all about antibiotic treatment of CID infections pre and post-extraction. We will cover all essentials on antibiotic therapy that you need to know to provide optimal care for your patient. I'm delighted to welcome Professor Dr Hagel. Professor Dr Hagel is an infectious disease specialist at the University Hospital in Jena, Germany, and he is here to talk with us about antibiotic treatment of CID infections. Welcome, Professor Hagel.
Thank you very much for the invitation.
Thank you for joining us. So before we go into detail regarding the specific antibiotic therapy of CID infection, why is it sometimes such a challenge to treat a CID infection with a standalone therapy with antibiotics?
The problem is that the biofilm is there, like all bacteria, or especially the gram-positive the bacteria, the staphylococci, they produce a biofilm matrix on the artificial surfaces. And with the CID you have a big surface, and these bacteria, they form a biofilm, and within this biofilm they hide these bacteria, and it's not possible to kill all these bacteria within this biofilm. And even if you treat for 4 or 6 weeks, you will never be able to kill all the bacteria. And after you stop antibiotics, these bacteria can make a recurrent infection. So therefore, it's always the recommendation to give antibiotics, but at the same time perform extraction of the complete device. Because if you leave some leads in the patient, you still have this biofilm and you have the risk of the recurrence.
Okay, so as you already mentioned, the key to successful treatment is complete extraction of all parts of the CID system. But as we've learned, antibiotic therapy is equally important to treat sepsis or septic shock. So let's have a look at the empiric therapy. So what is the recommended empiric therapy, let's say for patient A has a pocket infection and patient has maybe a systemic infection?
Good question. So first you have to think of which pathogens are in majority responsible for the CID infection. And it's like 80–90% of the pathogens are staphylococci. So you have the coagulase negative staphylococci, which are more often found in pocket infections. And then you have the Staph aureus, either oxacillin, methicillin resistant, it's the MRSA, or the susceptible. And then you have like a small proportion of other gram-positive pathogens, for example, Enterococcus fecalis, but this is less than 5%. And sometimes you have the gram-negative, Pseudomonas or Serratia, but this is really also very, like in less than 5% the case. And then if we go for the empiric therapy, you have to look at your patient. If you have a severely ill patient with organ dysfunction, even septic shock, and you have a mortality rate of 50–60%, you have to start with a broad spectrum antibiotic. You have to start with daptomycin or vancomycin to cover also the oxacillin and the methicillin resistant pathogens. In addition, you have to cover the gram-negative pathogens, for example with carbapenem or piptazo or cephalosporin. If you have a patient only with a pocket infection, and this is more like the patient comes to your clinic and he tells you, oh, it's like 4, 6, 7, 8 weeks, it's like a swelling and a redness, this is not a severely ill infection. And in these patients, I personally would start, for example, with vancomycin or daptomycin, because then you also have to cover the oxacillin, methicillin resistant, coagulase negative staphylococci, but definitely not the gram-negatives.
Okay, perfect. So I think that is the first clear message. So start with daptomycin in most of the patients, and in some patients with normal renal function, you can still use vancomycin and add gram-negative spectrum covering antibiotic therapy for those who are who are severely ill. So let's have a look at the treatment path of the patient. So what is the timing between the detection of the infection, antibiotics, and lead extraction?
This again also like looking at your patient. If you have a severely ill patient, for example sepsis or septic shock, you should start your therapy within like 1 hour, 1 or 2 hours. This is for septic shock. If you have a patient with a mild infection of the pocket, and very often these patients they come to the hospital and say, I have here for like several weeks this redness of the pocket, and then I think this is not that critical to start within hours. Here it's take the blood cultures and then you can start with the antibiotics. So again, severely ill patients start immediately with your therapy after taking blood cultures, and if you have patients like more or less long-standing infection, you can also wait for several hours, or maybe if you extract later in the day, you can also start antibiotics after the extraction.
Okay, and I think the other important thing is not to delay extraction and wait for the response of the antibiotics, but kind of start them or plan it simultaneously, right?
Yes, there's good data also again for the severely ill patients. If you have like a patient with sepsis or septic shock, the patients, if you do early source control, they have the biggest benefit. So do not wait until the patient stabilizes. So the earlier you do the source control, the better for the patient. And there's also data for the not so severely ill patient with a CID infection. If you do it within several days, I think it was the cutoff of 3 days, the earlier you do the extraction, the better is the outcome.
So you already gave us some very valuable insights on choosing which antibiotic to start. So you're an infectious disease specialist. Do you think we need a multidisciplinary team, including an infectious disease specialist? And if not, what do you recommend to people who are working at maybe smaller hospitals? Where do they get their information from?
This is a good point. We know from endocarditis that like the endocarditis team is a very good option to improve patient outcome, because you have different specialists from different parts like cardiology, heart surgery, microbiology or infectious diseases. And every colleague has its own expert knowledge. And if you combine these expert knowledge for one patient, I think this is best for the patient's outcome. And if you do not have all these experts available within your hospital, I think it's good to have at least one referral hospital where you can ask and discuss the patient what is the best option for the patient, which antibiotic is there, like does the patient need extraction, when is the best timing for extraction. I think this is very critical to discuss each patient case with some expert colleagues.
Yeah, I think that's an important point, and maybe also online participation in such conferences might be an option as well today. And so we now covered the empiric treatment. So let's have a look at the targeted therapy. So if we get back, if we get the antibiogram back, so how and how long should we continue antibiotic therapy?
Yes, I think this is very important. So if you start with your broad spectrum antibiotics, for example, vancomycin or daptomycin, and then you get the result of the blood culture, and it's like oxacillin, methicillin, the susceptible, the Staph aureus, you should de-escalate your broad spectrum therapy to, for example, cefazolin, because it's less toxic, it's cheaper, and it's also more effective than, for example, vancomycin. And concerning the treatment duration, it depends on the extent of the infection. So if you only have a CID pocket infection, it is recommended 14 days of therapy after the extraction. And if you have like a pocket infection with a positive blood culture and Staph aureus, it is the 4 weeks after extraction. And the same is true for if you have like lead vegetations or valve vegetation and you treat for endocarditis. So it really depends on where is the infection and what extent. So between 2 and 6 weeks, if you have a prosthetic valve endocarditis, this is the recommended duration.
Okay, so maybe a third clear, important message is the first-line therapy with cefazolin, as we were talking earlier today, for Staphylococcus aureus infections, because it's less nephrotoxic, right?
Yes, there is like a new data showing if you have a Staph aureus oxazolin methicillin susceptible, you have two options. One option is cefazolin, and the other option is oxazolin flucloxacillin. And there's new data from Australia showing that the therapy with cefazolin is less nephrotoxic compared to flucloxacillin.
Okay, so I think this is a very important practical message to our listeners as well. And so we have been talking about the antibiotic therapy in hospital, and then the ESC guidelines recommend a step-down therapy. First of all, the option of IV antibiotics. Via a so-called PICC line, we have the option of a long-acting substance like dalbavancin, and we have the oral antibiotics. So which strategy has which advantage, so to say, for the patient? So is IV better than oral antibiotics, or is the long-acting antibiotic maybe the best option? Can you maybe highlight this a bit?
Yeah, it really depends on the patient. So if you, and the patient preferences. So if you have a patient who does not like to give his own IV antibiotics, I think outpatient parenteral therapy is not a good option for him. Dalbavancin would be a good possibility in these patients, but also the oral antibiotics are a good possibility. But with the oral antibiotics, you have to ask your patient and to look at your patient. I think one key point is the compliance. If you have a patient with a bad compliance and he's not taking the tablets, this is not good for the patient. But all three options, they have the advantage that you can discharge your patient early from the hospital, so he can go home and show his family and his known the surrounding, and this is, I think, the very good point.
Okay, so patient preference is very, very important. But regarding outcome, do we have evidence for one or the other strategy?
There is no evidence between these three options. So there is no head-to-head comparison, which is better, dalbavancin, long-acting glycopeptides, OPAT, or the oral strategy. So there's no data, and I think it really depends on your patient.
Okay, so this is an important message. So we do not have to treat our patients in hospital for 4 to 6 weeks in case of systemic infection. So if the patient is stable, we can choose depending on the patient and depending on how stable the patient is, whether we go for the more intensive outpatient parenteral therapy, a prolonged antibiotic therapy, or we can also choose an oral antibiotic therapy. And if I got you right, with a combination therapy, and we have to take care that the patient can swallow, that the drug has a good bioavailability, but then we can choose that option as well. So we have a lot of options today. So thank you very much for summarizing the current recommendations on antibiotic treatment in CID infections. For all of those out there, if you want to learn more about antibiotic treatment of CID infections, listen to our podcast, go to the ERA website, or check the summary which is linked to this episode. We have a very nice summary by Professor Hagel, which highlights the top messages of this webinar. And never forget, the key aspect to successfully treat a CID infection is to extract the whole system. So thank you for your attention, thank you for listening, and we hope to see you again in the next podcast.
This podcast is supported by Philips.